So Patty has been involved for the last couple of years in efforts to reduce the burden of clinical documentation for nurses in the electronic health record, and is here today to share how we can begin to address this issue locally. So please extend a warm welcome to Dr. Sengstack. Thank you. Oh, you already have. Okay.
So can you guys hear me? Oh, this works really well, doesn't it?
You would want this to advance your slides.
Okay. I thought I'm going to try. Can you see me in the back? I'm kind of a wanderer and pacer. But I want to make sure that the people in the back can see me okay. So this is a hot topic, isn't it? We want to reduce the burden of documentation for our nurses and make sure that they can spend more time with their patients rather than at the computer. And so hopefully everybody's dealing with this, or hopefully you're starting to address this in your organization. So today I'd like to share with you a few objectives. So we want to, I'm going to define some of the contributing factors. How did we get here? How did this happen? And then some of the national efforts underway. What's happening with CMS and the Health and Human Services? How are they addressing this burden? And then I'd like to dive into some of the things that you can do at the organizational level, some things that maybe you can go back and start to work on today. But first, and let's just get this over with. Is anybody up for a game of gin rummy first before we start? You knew I had to do that, right? And see, you all are laughing, so I know everybody knows what I'm talking about. That was crazy. I understand she's gotten like 1,700 decks of cards to her office. Amazing. Okay, so just to show you what a hot topic this is, did anybody see this? Yeah, interesting article, and it's in Fortune magazine. It's not a healthcare, publication. So this kind of concept is starting to infiltrate the not healthcare world. People are starting to notice it, and it's a problem. I mean, definitely, this is so did you read this? So did people actually read? It was a long read, wasn't it? It was pretty long, and 4 videos in it. And I'm thinking if I want to give you my opinion on it or not. I really think that I don't disagree with anything that they said. But what I didn't see was what are we going to do about it? I'm not sure it was incredibly useful in terms of presenting some evidence-based solutions or strategies to going forward. What do you want the federal government to do about this? It was a lot of complaining, and I think we, and I'm looking at you, the proverbial we, have a lot of work to do. So let me share a little bit about how this got started in my world, and it's been a couple of years that I've looked at this concept, and it was when I was the Chief Nursing Informatics Officer for the Bon Secours Health System. We had a meeting, and all the chief nurses from across the 14 hospitals were together in one room with some other clinical leaders, and one of the chief nurses said, "It is taking the nurses way too long to do the nursing admission assessment. In fact, it's taking them about 2 hours." And I don't know if that's true or not. That seems like an awfully long time. And they all started nodding their heads and saying, yeah, it's taking way too long. And so they said, well, Patty, can you get it so that it only takes them 20 minutes? So fortunately, I'm thinking, spoiler alert, I left that job before I could do that. But I was fortunate enough at the time to have a graduate student working with me from the University of Maryland in the informatics program there. And I said, okay, we need some baseline data here. So I asked her to go into the nursing admission assessment and how many fields are there? How many clicks does it take to complete a nursing admission assessment? And I know that when you're filling it out, you don't fill out absolutely everything because it depends on the clinical picture of the patient. But I want you to count them all anyway. So she did that, and what you're looking at on the screen there is just a little piece of the spreadsheet that she dutifully created in Excel for me that had every click, every field, everything. And so at the end of the count, it was 539 clicks to complete it. So we started some work in that area. We started to figure out, okay, what are we going to do about this, and some strategies. But then I transitioned to Vanderbilt University, and I was fortunate enough there to have a student who was also interested in this topic. And so I asked her, would she be interested in working with her organization to do something similar, do a click count? So she did. She was at Virginia Mason out in Washington State. So her count was 459. And I thought, well, gee, I should probably count the clicks at Vanderbilt where I work. And I got to 500 and I just gave up. So there were probably even more than that. Okay, let's just face it, it's just way too many, way too many. So how did we get started? Where did this all start? So let me go back. I'm going to go way back, as a matter of fact. So the medical record actually does date back to Hippocrates back in the 5th century BC. It was a long time ago. And he noted that the patient's record should accurately reflect the course of the disease and indicate the probable cause of the disease. Well, that makes perfect sense, right? And I'm thinking way back when, they probably used hammer and chisel and granite and so they had to be really concise, right? You couldn't do a lot. And honestly, I don't really know what they used. They probably used, I don't know, papyrus or something with a quill, and I don't know. But they probably had to be really precise. And whenever I say that, I always think, I wonder if it was as difficult to transition from the granite and the hammer and chisel to the papyrus as it has been for us to go from paper to electronic. But so let's look at what the American Nurses Association says nurses should document. Let's go right to the source. What should nurses document? ANA has a nice set of principles, and they say these are the things that should be documented: assessments, clinical problems for the patient, communication with other healthcare professionals regarding the patient, communication and education with the patient and family, the medication record, medication administration, order acknowledgement, implementation, management, patient's clinical parameters like vital signs, the patient responses to outcomes, changes in the status, and plans of care. You don't see other things there, do you? You wouldn't disagree with this, right? This is a nice list. But things have changed, right? Things have changed. What were some of the major driving forces that changed having to document more things? Can you think of them? I'm hearing murmurings of some of the things that I'm going to share with you. Number one, we computerized it, we digitized it, right? Making it a lot easier to get things, more things in there. Also, documentation of services is a requirement for payment, right? Coding and billing. Medicare, Medicaid, private payers, they require documentations to get the money. And then I heard somebody saying regulation, legislation, some of the quality things, meaningful use, ECQM. All these things have made sure that we have more things added to the to-do list of documentation. And I know there's a lot of focus on providers, but there's not enough of a focus on what nursing has to document. And that's where you'll hear me say this again, we need to do more of this work and research and publish it, because it's all the research we look at, or most of the research we look at, is related to how providers are burdened. So remember these. Has everybody here charted on paper at some point in their career? Yeah. So I think many of the places that I've worked have always had me on the documentation committee, and I can remember working with a team to format these forms and make sure that the boxes are right and we're capturing the right thing, and then we'd have to take it to the graphic artist and make sure that we could get these boxes right and everything. Yes, everybody's like, yeah, we've been there. And then once you got it right, you send it off to the printer. And when you send it to the printer, then they will print it and they'll send it back to you in boxes and reams and boxes and reams. And you put them into a closet somewhere. And there's no way you're going to change anything until you've used all of them, because they cost a lot of money, right? They cost a lot of money. So you couldn't add anything. But now, because we've digitized it, how easy is it? I mean, I know it's more complex than just adding a field, because we all know, this audience in particular knows it's not quite as easy as that. But to add more things, add more fields, add this, add that, it's like the lid came off. And I feel like people that are not in our field think it is really easy to add this, add that. Just add it. So what is the purpose of documentation today? Number one, capture the clinical care provided to patients. And I think most of us would agree with that. And then communicate with other professionals. Now, wouldn't it be great if we could stop right there? But there's more. There's reimbursement. There's the regulation and the legislation. There's quality. There's accreditation, the Joint Commission. Legal purposes. And research. For those of you that work in a setting that may be doing research, you know that a lot of the times our researchers would like us to add some fields for documentation as well. So lots of reasons to document other than those first two and the things that the ANA have said. If you look at the literature, some of the things that we have found is that the nurses and physicians spend as much time as 30 to 50% of their day performing documentation activities. Now, a lot of these studies and publications, again, are provider focused and are some of them are perceptual. And so we need some more research in this area. We'll talk about that a little bit coming up. So national attention. This has gotten the attention of Health and Human Services, CMS. So there have been some initiatives. Did you know that the 21st Century Cures Act addresses the burden of documentation? I'm going to share a couple of things that are happening now related to that, as well as the National Academy of Medicine. You know, the National Academy of Medicine used to be called the Institute of Medicine. They changed it from the IOM to the NAM just to confuse us, but it's the same organization. And then the University of Minnesota, some of you may actually be involved in some of the work through the University of Minnesota, their Nursing Knowledge Big Data Science Initiative. Let me share these with you. So the 21st Century Cures Act, did you know that in section 4001A, that there is a section that has work that needs to be done by Health and Human Services, meaning Centers for Medicare and Medicaid Services, and the Office of the National Coordinator for Health IT. And I'm assuming this audience knows who I'm talking about when I say ONC. So it's asking them to do this work, pay attention to this work. Okay, so reduction, they want to establish a goal with respect to the reduction of regulatory or administrative burdens, such as documentation requirements relating to the use of electronic records, and to develop a strategy for making this happen. This was the charge in that 21st Century Cures Act. So ONC and CMS have been doing some work, and this has actually been going on for a couple of years. Have you heard of the initiative, Patients Over Paperwork? I learned about this actually a couple of years ago when I was starting to dive into this work. And I went to, in Washington, D.C., there was a meeting that they had that addressed this. And this Patients Over Paperwork has been, several subgroups have been addressing different things. But they've got this tagline, and you can Google Patients Over Paperwork, and you'll see they have a great website and some of the work they've been doing. But their tagline is, our top priority at CMS is putting patients first. And CMS is committed to reducing unnecessary burden, increasing efficiencies, and improving the beneficiary experience. So they've been doing a lot of work. And so at this meeting I went to last year in Washington, D.C., they were highlighting some of the things they were working on. So let me share some of those with you. So the evaluation and maintenance that medical students document, they used to have to rewrite the whole thing. Now they don't have to be rewritten, they can just be signed. Signature requirements, the claims won't be denied if staff forget to sign it. A lot of times there are things that are initialed, and so those initials now are okay, and that claims won't be denied. They've also greatly reduced the number of EHR measures and thresholds required for meaningful use in the quality payment program. And then for those of you who are interested in therapeutic shoe inserts. They brag about they now allow payment for inserts made with digital technology without an actual impression of the foot. So that's good news if you need a shoe insert. They've been doing a lot more work than that. I just thought that was a funny one. But we need to know about these. We need to know if we don't need to do anything anymore so that we don't do it anymore. And I just encourage you to go to the website and look and see what kind of work they're doing and what they have planned. The administrator of CMS, Seema Verma, she's been so supportive of this work and has charged her group with doing things like simplifying the requirements, make them easier, please make them, this is to her team, please make them easier to understand, get rid of things we no longer need, get input from stakeholders, challenge what we've always been doing. And they've actually got a place where you can submit input. So if there's something that you know needs to be changed or addressed in some way, she's given you a website address where you can submit it and say, hey, can you fix this? It's taking us way too much time. So I encourage you to take a look at that if you have something that you might want to have them change. Okay, the second thing, and this is also with the 21st Century Cures Act, is that strategy. Remember, one of the things in the 21st Century Cures Act says put together a strategy plan. This came out. This is, I wouldn't say this is hot off the press. This is kind of warm off the press. This was put out for public comment back in, I think, November or December in 2018. Put out for public comment. A draft came out. And it's the strategy on reducing regulatory and administrative burden relating to the use of health IT and EHR. Did anybody see this? Take a look, if you get a chance. Well, it's a little bit longer. It's 74 pages long. And hopefully the feedback that they're getting is to, can you condense it? Because when you read it, there's a lot of repetition in it, I thought. Anyway, I was on a webinar, was it last week or the week before, with AMIA, and they brought onto the webinar some of the people who were helping to author this. And their comment was that there were hundreds of people that gave input into this plan. And they are taking it and they're kind of digesting it and they're trying to figure out what to do next with it, and it will be published in its final form sometime this summer. So I think it would behoove all of us to take a look at that and read it and find out, what recommendations do you have? What is the strategy and how can we implement some of these things in our organization? They have these very straightforward goals that I think you'll agree with. They want to reduce the effort and time required to record information in EHRs. Right? They want to reduce the effort and time required to meet regulatory reporting. And they want to improve the functionality and intuitiveness of EHRs. And we would call this usability, and improve the usability. They have in the document, I know you can't read this, and it wasn't intended to have you read it, but there are these tables in there, and they have the strategy and the recommendation. And this is what people gave feedback on. And I think that in reading over them, I felt like the recommendations were good. I mean, they made sense, but some of them I thought were pretty high up there. Continue to reduce overall regulatory burden around documentation of patient encounters. I'm not sure what I would go back and do in my setting with that. So some of them, I think they needed to be in the weeds a little bit more, and they've gotten that feedback. So we'll see what happens. So we should be looking for this. One of the authors of it said it should be out in its final version sometime this summer. So be looking for this. Okay, the National Academy of Medicine, formerly the IOM, they've published a couple of documents, or they call them, it's an interesting term, discussion paper. I'm not exactly sure what a discussion paper is. It's not a position statement. It's not a white paper. It's a discussion paper. And I think that the reason these were published was to help to inform the Health and Human Services groups, the ONC and CMS, as they start to do some of their burden work. And so this first one, care-centered clinical documentation in the digital environment, solutions to alleviate burnout. in this, it has some strategies. And I'm sure that they've used this one and another one I'll show you to help to inform that plan that I just showed you. So this one, and then the other one is a vision for person-centered health information system. And this one is kind of future thinking and has some scenarios about what that patient-centered EHR will look like. And there's some great vignettes in there where there's kind of a Siri person in a clinical setting where it says, Siri, and I think they use Clara in that, which I thought was very appropriate. Clara, show me the last results of the patient's chest x-ray, or show me the last set of vital signs over the last month. And so all these things, of course, would come up on the screen. And so, they kind of look to give a futuristic version of what a healthcare or what an electronic health record should look like in an ideal world. It's kind of an interesting read. And some of the things they share in there, some of the highlights I just will pick out here, is that they say that clinicians should be responsible for only essential primary data that is required to support the care of the patient, which is what we've been talking about already. The EHR developer should increase the development of capabilities that allow clinicians to understand previous medical health and social history of the patient. So it's patient-centered. Data follows the patient no matter where they got the care. I know that some of you could probably tell stories about this. I moved from the Maryland area where I was a Kaiser patient, and they're on Epic, and then I moved down to Nashville, Tennessee, and worked at Vanderbilt, who now, as of a year and a half ago, is also an Epic user. So when I went to go to my provider, I thought, well, let me go to my Kaiser patient portal and download, my blue button, and let me get my data. Well, guess what? Kaiser said you can't get your data anymore electronically because you are no longer a patient of ours. But you can make a request if you fill out a form and mail it to us with a stamp, and then we'll send it to you. And we can send it to you electronically, which they did. I have 30 years of data from there. They sent me a 447-page PDF. That is, not... Anyway, that's the point of this one. You all could probably tell a similar story, couldn't you? So CMS should also de-emphasize documentation requirements as a condition of payment for healthcare services. And then, as any other professional body will recommend, more study is needed. We need more study. We need more focus on this problem. And then the last national effort I'll share with you is the one out of the University of Minnesota. Is anybody here involved in this, the Big Data Initiative? A couple of you. So they've been doing this for a while. They've got 10 work groups, and they're developing this framework of a topical series, and they have subgroups. So one of the subgroups that's been working pretty hard lately is a group that's looking at the nursing admission assessment. So near and dear to my heart, in particular, the focus on the patient history section. So they're getting together, and this group is actually led by Jane Engelbright, if you know her, and she's the CNO at HCA in Nashville, Tennessee. And that group, hopefully, because I had lunch with her a couple of weeks ago, the presentation of the standards for what should be in a patient history section, the recommendations for that, she'll be sharing this summer sometime. So hopefully we'll see that. It would be nice if we could all just say, we're only using these essential elements and that's it. We'll see. So look for that as well. And this, excuse me, I just saw this come across my email the other day, and I thought, well, let me share it. It's sort of peripheral, but I thought it was interesting. So you're familiar with KLAS reports? They had one where they looked at how satisfied are nurses and physicians with the electronic health record. And isn't this interesting? I know, and if I had any feedback to give them, I would tell them that because this is just a screenshot from the report, their foreground and background contrast ratio and this visual representation is terrible because you can't see the orange there. But the nurse experience with the EHR is at 41, their score is 41.7, whereas the physician's is 16. So I don't know why that, that'd be like another conversation to have, another presentation as to why is that? You can think of a lot of reasons, why are the nurses like, okay, yeah, it's okay. And the docs are a little more grumbly about it. I don't know, interesting. And they also asked, they have agreement that the EHR, agreement that the EHR keeps the patient safe. Does it keep the patient safe? They asked the nurses. Does it enable quality care? And does it help deliver patient-centered care? So you can see the blue dots are the physicians and the orange dots are the nurses. So the nurses tend to be a little more positive about the electronic health record, which for us who are more interested in, wow, we're this little biased here, aren't we? We love our nurses. This is a good thing. This means that they don't totally hate it. There maybe there's some hope here. We can continue to make those improvements. So think globally, act locally. Do you like how I have my little arrow where we are? I did that on purpose. I want to share with you a framework that I've been developing with some people called the 6 domains of burden. And don't glaze over when I say the word framework. When you hear about a problem like burden, and people are talking about the burden, you kind of put on your quality hat and you think, I think there are lots of different reasons for the burden, right? There's lots of different reasons for it. And for those of you in quality, you think, well, we should probably do a fishbone diagram or Ishikawa diagram or something here. And so we did. And we thought, okay, well, what are the different reasons for burden? And y'all are thinking, I want you to think about these. And we put them, and we called them, to make it sound really fancy, like a framework, we called them domains. So don't, that's the academic side of me. You can make something that's like really simple and make it sound really sophisticated and academic if you put a word like domain on it. So 6 domains of burden. Number 1, reimbursement. Documentation that needs to be done, CMS, the payer, say you need to document. To get paid, you need to document. Regulatory, accreditation agencies, documentation requirements. So Joint Commission, and there's some state agencies and others that require documentation. Quality. Were you thinking of this one too, right? Quality. So documentation that's required to demonstrate that that quality patient care has been delivered, and not just requirements that are governmental and regulatory, but sometimes there are organization quality requirements that need to be documented. I guess the next one? If I'm right, this one is, to me, the most important one. Yes. Usability, right? Limited and insufficient use of human factors engineering, human-computer interface principles resulting in extra time spent entering data, scrolling for data, clicking and searching for the pertinent information that you need. Some people use the word foraging for information. Usability. Interoperability, use of standards. Right? We know we see insufficient configuration standards that result in duplication, re-entry of data, even though it resides somewhere else, either internal or external to the organization. We see some we see that burden with interoperability. This last one, I'm going to spend a lot of time talking about this last one. We've done it to ourselves. Because here's where I think we can make the biggest difference. And forgive my very rudimentary picture because I'm not a graphic designer, but if you look at these 6 domains in a kind of an infographic, you know that all of them live in that bubble of usability. Usability. If a billing and coding system is created that's so accurate and detailed, it's perfect, but it's not user-friendly, it's not going to work. Lack of interoperability. If you have a 447-page PDF that's plunked into the media tab, that's great. I've got all the information, but I'm never going to be able to find what I really need, right? So it's got to be user-friendly. And then those domains of regulatory and quality, I think, overlap a bit with self-imposed, because I think sometimes that the way that we interpret the regulatory and some of the quality requirements, we maybe we misinterpret them, and maybe we don't need to document as much as we do. I'm going to spend some time, like I said, focusing in on this self-imposed one. What can we do about it? Let's define it. So the organizational culture's influence on what should be documented can exceed what is needed for patient care, including these things. And I think we're all familiar with these. There's fear of litigation. We've always done it this way mentality. We've been dealing with that for a long time. Misinterpretation of regulatory standards. And then we have some very powerful interest groups that want something and it goes right in. Overzealous risk managers. Sometimes insufficient education on system use, or maybe outdated organizational policies. Let me give you some examples. I can't remember. I was giving a talk one time about something like this, and Mark Shagru, I was talking about governance and methodologies to prioritize, strategies to prioritize what gets put into the system. And I remember Mark Shagru, and I was talking about what we were doing at Bon Secours, and Mark Shagru raised his hand. He goes, we figured it out. And I said, how'd you figure it out? He goes, we used the squeaky wheel methodology. And I said, well, how's that working for you? And he said, not so well. I'm sure you all have experienced that. If somebody, is a squeaky wheel, or you know who I'm talking about, you're maybe high, powerful people, then sometimes you get things put in that may not really add to the clinical care of the patient, but for some other reason. Okay, excessive documentation on admission to the hospital. We know that there's a lot of documentation on admission. Our end users are often not aware of some of the functionality that can improve their effectiveness. They're doing the 10-click step methodology when there really is another way to do it in 2 steps. They just either weren't taught it when they were trained, because you know how it is when you train people, they just get them through. There are ways, and we need to work on some education. And then there's this extra CYA charting. There is a fear of litigation. I'm going to show you an example of that in just a minute. It is out there, and it's strong and alive and well. And the nature of nursing and the desire to capture more than necessary to provide and communicate the essentials of care. Am I allowed to use the word anal retentive? I'm telling you, nurses are. It's kind of our nature. We like to document a lot, and I think we need to sort of think about that. The answer to my question is in front of you. But what is the one thing that we as nurses do, and any of the nurses do, to make our patients safe? Wash your hands. Do we document that? Do the nurses document that? Why not? It is, I mean, let's face it, it is the most important thing that our nurses can do to give good care, to make sure their hands are clean. And yet we don't document that. Why not? Why don't we document that? But couldn't you say that about 100 other things the nurses do? I mean, it's food for thought. And some organizations do better than others about saying, well, this is a standard, so we don't document it. But there are places that still, if it's not documented, it's not done. How can we improve what we can control? Let's get down to some things that maybe we can start to look at in our organizations. Review patient care policies and procedures. Search for, I know you all know how to do this. If you took your policies or your procedures and you did a search, you can do the find and you type in the word document. See how many places the word document is located. And then look and see, do I really need to document that? What for? What am I can we stop that? And then review documentation needed for accreditation agencies. The Joint Commission has, if you've looked at their book or their standards, if it's something that must be documented, they have this little symbol next to it that says this one requires documentation. But not all of them do. So we need to look and see if it does or if it doesn't. And if it doesn't, then can we stop doing it? The Joint Commission has an initiative that's been going on since 2016 called Project Refresh. And they brag that in phases 1 and 2, that it's resulted in the deletion of about 300 elements of performance. So do you know which ones we don't have to do anymore? We need to find out. We need to make sure we're not still doing something that we don't have to anymore. And so in my conversation with Jane Engelbright the other week, she told me she sits on the board for Joint Commission, and she said that they came and did an inspection at one of her survey. Feels like an inspection there, doesn't it? She said they came to one of their facilities, and they were looking for documentation. No, she said that they didn't like their care plan. You know, we don't like your care plan. It's not. Do we want to talk about care plans now? No, let's not go there. She said that she pushed back and said to the surveyor, show me in your standards your complaint, your specific complaint. Show me in the standards where it says I need to document that. And they couldn't. And I feel like, well, Jane Engelbright, she can push back. And I'm not so sure the rest of us can. But we need to know, we need to be evidence-based. So it says if there doesn't say we need to document it, let's think about it. And evaluate what's currently in the system. My student that I talked about that's in Washington State carried out the project I was trying to do at Bon Secours Health System when I was there, and taking that nursing admission assessment and going through every single solitary element of it. She had 127 elements in their nursing admission assessment, 127 items. So those 127 items got listed. This is just a screenshot of that spreadsheet. She asked 10 questions to every item, 10 questions to every single item. Is it imperative or required to document that data element for the clinical care of the patient? Is it important to document for the communication of the patient information to the care team? Is it a regulatory requirement? Does it trigger an alert? Is it documented elsewhere already in the chart? Is an RN required to document it? Is it required for the first 8 to 10 hours of admission? And is it something that every patient must be asked? It's pertinent to every patient. And is it pulled into the patient header? And is it needed for some kind of reporting? So their group of stakeholders went and asked all those questions to all 127 items. And what they found was that 30 of them were recommended for retaining or keeping in there. Yeah, we need these 30 things. 40 of them they recommended for getting rid of. And 57 of them, they said, I'm not sure we should review these. 40, that's 31%. That's a third of the items in there, and that's a lot. So of those, let me go back. Of those 40, and she had a scoring system that she used, but 10 of those 40 had a score of 0. So I'm thinking, how did they even get in there? But they were, and so none of those 40 that were recommended to take out were identified as being required by a regulatory agency. One was used in some type of CDS, and only one was for discharge planning. But removing all 40 items had the opportunity to decrease their documentation by 31%. This is a lot. It's a lot of work. It's tedious work, but I think it will definitely pay off. Okay, now I'm not going forward. There we go. Okay, clicker issues. Use data to make informed decisions, and that's what we do as informaticists. There's an article that was written, and if you haven't seen this, you should take a look at it. This was written by Eva Karp, who works for the Cerner Corporation. And you may know Rebecca Freeman, who was the former, what was her title at ONC? She was the CNO at ONC, the CNO at ONC. And they looked at one of the organizations in Cerner did kind of the same thing. And but they got their data elements in the admission assessment from 215 to 58, and I want to know what they did and what they were. Well, they're working on a second publication that will address that, but this particular article talks about the ability of the vendor now to capture how long the nurses are staying in the system and what they're doing in the system while they're in there. So we're starting to get data from our vendors to help with this, and we need to partner with them. And so we're an Epic shop, and so those of you that are on Epic might be familiar with the provider efficiency profile or the nursing efficiency assessment tool. And this is one where Epic is providing us data for about a month of time when the nurse and capture when the nurse goes into the system, timestamp, when the nurse leaves the system, timestamp, and then where the nurse is during that time. Are they in flow sheets? Where are they spending their time? This data can help us as informatics specialists to help to determine where do we need to focus some efforts. Maybe it's an educational issue, or maybe it's some workflow or usability issue that people are spending too much time in one area. But we need to start using this data with, in partnership with our vendors. One of the things I was asking our vendor was, give me some data about the flow sheet rows. The flow sheets are so busy. Are there any flow sheets that we're not using? Can we get rid of them? Are there any flow sheet row elements that have not been used? And let's get rid of those too. So I asked them to do this, and this was last year, between February 20th and March 20th, 2018. And they found that there were 7,851 unique flow sheet rows that were documented on during that time, representing over 12.5 million data elements that filled 9 Excel worksheets. So what do I do with that? So I started looking at it, and they gave us data related to flow sheet usage by department, flow sheet. It's hard to say that word really fast. I'll slow down. Flow sheet usage by security template, and then flow sheet custom list usage. So that data is interesting, but not so sure we can really do anything with that. What I did find fascinating, though, was they also gave us the data on what kind of comments people are putting into the flow sheet. And I looked at, I'm going to share with you the blood pressure example. When a nurse goes in and enters a blood pressure, there's that little box that looks like it looks like a piece of paper with a folded corner, and you can click on that and you can type in whatever you want. I mean, it can be short, it can be long, it can be. And we looked at vital signs. We just picked vital signs. Let's see what they're putting in here for vital signs. For during that month, remember this is just 1 month, how many comments do you think nurses, free text comments, do you think nurses made just for blood pressure? 5,325 just for blood pressure. Temperature was a mere 2,000. Pulse ox, 1,431 and on down. I thought, my goodness, what are they typing in this free text box? Anybody want to guess what kind of stuff they're typing? What did I mention earlier? CYA. So let me show you some of the things. I don't know, some of you might not be able to read all these. Patient states he felt dizzy when he leaned his head back. MD page, nurse notified. 100 milliliter bolus of normal saline given. Page physician. Will recheck. Appears to be sleeping. Patient screaming and crying. Will recheck. MD notified. NP notified. I can tell you that if you look at all these 5,000, 80% of them are someone was notified. And some of it had some really interesting clinical information in it. But that comment, as those of you, I know you're all familiar with flow sheets, what happens? They move on down and then they're gone. And so at this point, I mean, even today, we haven't figured out what to do with them. Do you put them into a summary view of some kind? But why would you put MD notified in a summary view? So we're still trying to figure that out. We're thinking, well, could we give them like a little box that says MD notified or RN notified, if it's a patient care tech that did it. So interesting stuff. So go back and find out what's in your, not what's in your wallet, right? That's an ad for some bank. Find out what's in your comments. This only represents a small piece of the comments. You know there's many more as well. So in summary, what should we do? What should we do? What can we do? We should stay informed of the changes that are happening by the federal and regulatory agencies because, right, if we don't know, we can't capitalize on some of those efforts to streamline and reduce the burden. If we don't have to do it anymore, let's not do it. So Joint Commission's efforts, CMS, patients over paperwork, and let's pay attention to what's going to come out of the University of Minnesota's work on the patient admission, patient history. Let's go back and reevaluate our interpretation of the regulations. Let's make sure it really does say we need to document a particular item. Look at our own policies and procedures. Search for the word document and see if we really do still need to do that. Let's clean up some of the clutter. Right? Use the data available. Let's partner with our vendors and get the data from them so we can focus in a meaningful way where we want to focus our efforts. And let's continue to work, I know many of you already are, as we are at Vanderbilt, helping to improve some of the usability and some of the workflow support, increase efficiencies. So let's standardize where possible. And let's innovate. I know there's a lot of work around using mobile technologies, voice recognition, device integration. A lot of these things that we're working on every day will help to reduce the burden. So let's keep pushing. And publish it. Publish. I know we have a lot of resources here in this area to help publish these things, and it would be great if we could see more and more publications around nurses' documentation, streamlining, decreasing the burden from the nursing perspective. And then develop guiding principles in your organizations to improve and enhance clinical documentation. So yeah, this is another whole conversation about how do you set up a governance around bringing in new pieces of documentation. I know most places have lists that are hundreds long of new things, the new changes, new enhancements, new things to document. And you need governance around how to handle that. How do you triage those things? How do you prioritize those things? What's more important than the other? So I think that it's really important to figure out what are your guiding principles. Does anybody have guiding principles that they use to look at? Okay, well here's the good news. I've been collecting across the nation anybody who does, and I have a DNP student this year who's going to be taking them and consolidating them, summarizing them, looking for evidence, and coming out with a set of guiding principles that we all can use when we start to triage and prioritize new documentation that comes into the system. So here's my thoughts for that, my ideas for guiding principles. And that's it. We're done. Yeah! Okay. Okay, now let's be real. Let's be real. We won't have any more documentation unless it's mandated, unless it's based on data and evidence. How many times do people come with these crazy requests? And do you have any evidence or data that that's going to work? Unless, and some of these are a little out there, but I put them just out there for food for thought. And unless we've identified how that data that's entered into these new fields that we're going to add will be used, how's it going to be used, and what actions will be taken, and by whom, based on what's entered. We should be asking that question, and I really like this next one. Whoever is requesting it, the responsible party for that addition, they come back and in some forum, they report the outcomes that they've achieved as a result of entering it at 3 months, 6 months, and 9 months. Let's do that. And then, of course, that addition needs to be vetted by some kind of a governance process. So hopefully you have some kind of a forum or group that meets and talks about these things. And this last one I call the shoe scenario, where this my husband says, when I come home with a new pair of shoes, he says, well, you got to throw a pair out. So if we add something, let's take something out to balance it out, if that's possible. And I believe, how am I doing on time? Did I do good? Okay. And that's it. All right, thank you all very much.